Good evening, one and all respected seniors, esteemed faculty, dear colleagues, and members of the Indian Thyroid Society. On behalf of the Indian Thyroid Society, it gives me immense pleasure to welcome all of you to another engaging session of the Wednesday Special Thyroid Clinics. So let us start the session with a video of the Indian Thyroid Society highlighting the society's missions, its initiatives to create awareness of thyroid health all throughout our country. So I request the tech team to display the video.
तस्य भासाय सर्वमिदं विभाति.
Thank you for that. So before we begin, we should first acknowledge the leadership of IPS. So we have our President, Dr. Narendra Kotpal Sir, President-elect, Dr. Pramila Kalra Madam, Secretary, Dr. Arun S. Menon Sir, Treasurer, Dr. Mini Ma'am, and EC members, we have Dr. Roma Pradhan Madam as well. So, and from the thyroid part of the thyroid clinics, we have Dr. Chitra Ma'am and Dr. Vijay Bhaskar Reddy and myself. We are all part of the thyroid clinics. So a short announcement before we proceed further. So we have our flagship journal, that is the Thyroid Research and Practice Journal. So whoever are interested to submit their research can do so by scanning the QR code displayed on the screen. So, and those who are interested to become a reviewer as well for the thyroid research and practice can do so by scanning the QR code displayed here. So this will help you sign up as a reviewer as well. So moving forward, today's session definitely is going to be very engaging. We have a very interesting case presentation and a focused surgical discussion and also a very exciting quiz session coming up. So the evening case presentation is basically from 8 p.m. to 8:30, where we have a case presentation by Dr. Suhas. And to moderate the case further, we are privileged to have two esteemed moderators, Dr. Santosh B. And Dr. Rana Bhattacharjee sir. And we are truly honored to have both of you moderating for today's session. So our next session will be a monologue presented by Dr. Sanjay K. Yadav, who will be sharing the role of transoral approach in thyroidectomy, and followed by this will be a quiz by Dr. Pooja Kamath. So to start off, I request Dr. Vijay sir to introduce the moderators. Over to Vijay sir.
Thank you, Dr. Ganavi. It's my honor to introduce the moderators for today's case presentation. Dr. Santosh B., Consultant Endocrinologist, Bangalore Baptist Hospital, Bangalore. And he is MD General Medicine, DNB Endocrinology. He's got 14 publications in peer-reviewed journals and 2 book chapters. He's also investigator in ongoing multi-center clinical trial. Welcome, Dr. Santosh.
Thank you, sir. Thank you.
Next moderator for today is Dr. Rana Bhattacharjee G, Associate Professor, Department of Endocrinology, Medical College, Kolkata. He is Associate Professor and he is MRCP, DM Endocrinology and FRCP and FACE. He has received Dr. J.C. Patel and Dr. B.C. Mehta Best Papers Award from JAPI, and he's received A.R. Seth Award from the Endocrine Society of India, which is a prestigious award. He's got more than 100 publications in peer-reviewed journals and authored more than 14 textbook chapters. Welcome, Dr. Rana.
Yeah, thank you, Dr. Vijay.
So, with this, I invite Dr. Suhas M, who is DNB Endocrinology at Bangalore Baptist Hospital, Bangalore. So, he will be presenting on the case when antithyroid drugs backfire, blood drought and biliary blues. So we use antithyroid drugs commonly in the endocrine practice, and occasionally we land up with these severe complications. So welcome, Dr. Suhas. You can go ahead with the presentation.
Thank you, sir. Thank you, sir. I'll start my screen sharing, sir. Yeah, start. Sir, am I audible, sir?
Yes, sir. You can go ahead. Slides are with you. Yeah.
Okay, sir. Good evening, everyone. I'll be presenting a case of a 43-year-old female who was diagnosed with hyperthyroidism like around 1.5 months prior to her presentation to the hospital. She was on medication and she presented to the emergency department with complaints of fever since 1 day, loose stools and vomiting since 1 day, and cough with minimal expectoration since 1 day. History of presenting illness, patient presented to our ED with complaints of fever, which was lasting only for 1 day, sudden onset associated with chills. Also, there was history of loose stools around 10 to 12 episodes in the last 1 day, water inconsistency, non-blood tinged, associated with vomiting, 2 to 3 episodes, which was not blood tinged and contained food particles. There was also history of minimal cough with expectoration, expectoration being mucoid and white in color. However, there was no history of abdominal pain, hematemesis, melena, or hemoptysis. There was history of palpitations, increased sweating, tremors of the hand, and intolerance to heat, which was lasting since almost 5 to 6 months. But however, there are no compressive symptoms in the form of dysphagia or hoarseness of voice, eye pain, eye swelling, or redness of eyes. Patient had the similar complaints of palpitation, sweating, heat intolerance associated with weight loss of around 10 to 12 kgs unintentional in the last 5 to 6 months, and for which patient visited outside hospital 1.5 months back, that's in October 2022. That time a baseline thyroid profile and CPC was done, which showed T4 and T3 being elevated up to almost 2 times the upper normal limit, with a suppressed TSH with normal hemoglobin, total counts, and platelets, for which patient was diagnosed as hyperthyroidism. He was started on carbimazole 15 mg OD and propranolol 20 mg BD. Also, but 1 week back, patient visited the local physician where the dose was increased to 50 mg per day, that is 10 mg 5 tablets. The reports of that time when it was increased is not available. No history of significant history of any other drug intake or over-the-counter usage of medications. Family history, nothing significant. Personal history, diet was mixed, appetite was reduced, sleep was disturbed. There was no deleterious habits. Coming to general physical examination, patient was
Before moving to examination, Dr.
yes,
Suhas,
sir. Yes,
a
sir.
small question. I mean, in baseline, you mentioned that you had a total count. Okay.
Yes, sir.
So it's very usual to have a differential count as well. Why it's important to have a differential count in the very beginning?
Yes, sir. Like usually, like if the in the differential count, if the neutropenic, if the absolute neutrophil count, if it is less than 1,000, like usually we do not start antithyroid drugs, sir. We'll wait on that. But
Anything
here,
else?
apart from the neutrophil count, sir.
No, with neutrophil count. You said that if it is less than 1,000, you may not start antithyroid drug. That's
Yes,
one.
sir. Yes,
And
sir.
number two, anything else? Say if it is 1100. So how does that help you in the follow-up?
Sir, I didn't get your question. Sorry, sir.
Say the differential count you did and your ANC is 1100.
Okay, sir.
Okay.
Yes, sir.
So we'll start your therapy, right? So how
Yes, sir.
does
Yes.
this baseline count help? If it is 1100, but how this information helps you?
Sir, and usually like we follow usually routine monitoring of absolute CB or the differential count is not done, sir. But
No,
whenever it is
not routine monitoring. I'm saying the baseline
baseline.
neutrophil count is 1100. So
Okay.
how does it help you in the follow-up? Is it important?
So like they're more prone, they'll be prone for like neutropenia secondary to the antithyroid.
Is it? Is it?
Like
I don't think there is no evidence of that.
okay,
But
sir.
can it be slightly low in Graves' disease or any other thyrotoxicosis itself? Can neutrophil count be low to begin with?
I'm not sure. I'll see, sir.
Okay, yeah, it can, and that's very important because
Okay, sir.
if patient develops some symptom down the line
Okay,
and
sir.
you measure the differential count there, and if you find that the count is bit low, then you are not sure that whether it was low from the very beginning and it's maybe improving, or is this reduction of neutrophil count is a recent one, which will make you more cautious regarding or which needs a close follow-up. So it's very important to have a differential count, and it can be low in any case of thyrotoxicosis. It's not
Okay.
specific for Graves even. Okay.
Okay, sir. Yes, sir. Yes.
Anyway, go ahead. Go ahead.
Okay, sir. Yes, sir. Yes. Coming to general physical examination, patient was moderately built and nourished with a height of 155 centimeter, weight of 55 kg, and a BMI of 22.9 kg per meter square. On arrival to the emergency department, BP was 60/40, patient was in shock, but pulse rate was only 104 beats per minute, probably since the patient was already on a beta blocker. Respiratory rate of 34 cycles per minute, patient was febrile with a temperature of 99.8 degree Fahrenheit. Pallor was present, icterus was also present. However, there was no cyanosis, clubbing, lymphadenopathy, or pedal edema. Dehydration was present. On head to toe examination, there was grade 2 goiter present, which was diffuse, non-tender, firm, soft to firm in consistency. However, there were no nodules palpable in the thyroid. There were no lymph nodes palpable. There was no bruit heard. Fine tremors of bilateral hand were seen. However, there was no eye involvement. That is, clinical CAS was 0 in both the eyes. Birch Waldorf score came to 40, like because of the fever, because of jaundice, and because of tachycardia and presence of a precipitating event, and like correlating with impending storm. Coming to systemic examination, patient was anxious examination, but however, there was no agitation or altered sensorium or delirium, and fine tremors were present. GCS was 15 out of 15, and other central like motor and sensory examination was normal. Cardiovascular system S1 and S2 heard, and there was just tachycardia seen. No obvious systolic murmurs heard. Respiratory and abdomen examination was normal. So at the end of the history and examination, a provisional diagnosis of acute gastroenteritis with severe dehydration with hypovolemic or septic shock was considered, and thyrotoxicosis with impending storm and the etiology being query Graves' disease, and the cause of anemia was yet to be identified. And with this history and examination, in view of shock, patient was shifted to ICU and started on IV fluids and inotropes.
Just hold on a moment.
Yes. Yes.
In your provisional diagnosis, I mean, it's a dictum that in a patient who is on antithyroid drugs,
Yes, sir.
if someone develops fever,
Yes, sir.
so always will think about agranulocytosis, right?
Yes, sir.
So
Yes.
that doesn't feature in your differential over here,
Yes,
because any fever that
yes.
you should always think about, although it's rare, but in the background of this,
Yes, sir.
always think about, and particularly if there is presence of sepsis,
Yes, sir.
then again it even make it more likely. Okay, go ahead.
Yes, sir. Okay, sir. Yes, sir. So on the day one of admission, the investigation is as follows. Patient had a hemoglobin of 8.9 gram per deciliter with the MCU of 72. The WBC count was 800 with ANC observed neutrophil count being 80 and platelets being 1.2 lakhs per millimeter cube. Thyroid profile showed FT4 was 2.25, that's around 1.5 times the upper normal limit, and a suppressed TSH. Liver function test showed hypoalbuminemia. It showed direct hyperbilirubinemia, that is total bilirubin of 6.8 with direct bilirubin of 5.2. However, enzymes and AST80 and ALP was normal. It was within normal limits. There was slight. There was AKI, that's creatine of 1.4 with coming to electrolytes. Potassium was 3.3. ABG showed metabolic acidosis with lactic acidosis with lactate of 3.2. Calcium phosphorus and was normal. The sepsis markers procal being was elevated. It was almost 40.81, indicating severe sepsis. Coagulation profile was normal. Urine routine showed bilirubin present. Once again, correlating with direct hyperbilirubinemia. Peripheral smear showed microcytic hypochromic anemia with both leukopenia and thrombocytopenia, and the viral markers were negatives.
So at this stage, what's your provisional diagnosis now for this current presentation after getting these reports and having clinical picture of this patient?
Sir, with this, at this point of time, there is pancytopenia, sir, with neutropenic sepsis with septic shock, sir. And
Right.
along
So
with
what are the probabilities? Your provisional diagnosis first, and then your differentials with all
yes,
this data that we have.
yes, like first because in the context of recent sudden increase of the antithyroid drug dosage, almost 50 mg per deciliter, I would definitely think of antithyroid drug-induced agranulocytosis here. And in this case, there is pancytopenia also, and since there is only a short history of only 1 day of fever, probably because of the neutropenic sepsis, patient had landed in septic shock. And there is usually, and whenever patient presents with sepsis, usually there will be some amount of transaminitis, and patient was also in shock. But however, here there was no transaminitis, and there was only predominantly direct hyperbilirubinemia, which can be seen with antithyroid drugs. AKA is probably because of dehydration and loose stools. Hypokalemia, once again because of loose stools, but it can happen in thyrotoxicosis also. And elevated procal, once again indicating towards septic shock.
So again, your provisional diagnosis.
So my provisional diagnosis at this point of time will be neutropenic sepsis with septic shock, sir. Pancytopenia probably second to antithyroid drugs. Direct hyperbilirubinemia also acute liver injury secondary to secondary to antithyroid drugs and with thyrotoxicosis with impending storms.
Do you still no? So thyrotoxicosis, impending storm is in your provisional diagnosis. So both agranulocytosis and thyroid storm, both are still there. I mean, how likely it is a patient who has a
Yes.
recent increase in antithyroid drug doses
Yes, sir.
and the T4 level is not that high
Yes.
and who is apparently compliant. So how
Yes.
likely the patient is having thyroid storm here?
Yes, like actually that both can cause because hyperthyroidism itself can cause pancytopenia also, so because of immunogenic and maturation arrest of the bone marrow cell.
No, I'm not talking about that. It can be drug induced. That's one thing. But how likely is the
Yes.
storm? Given
Yes.
the T4 level, which is not very high,
Sir,
and
it is,
there is no history of non-compliance, rather there is recent increase in drugs, so it's very unlikely that that T4 level has suddenly increased. So how likely is the storm in this background?
yes, it is unlikely, sir. Like usually
It's almost, it can be ruled out.
it almost
Right?
can be. Yes.
Whatever may be Birch-Rhodowski score, that
Yes.
score applies to appropriate clinical context.
Clinical
Okay?
conditions. Yes.
So there should be adequate thyrotoxicosis or a history of non-compliance where there is sudden increase in T4 level. So all
Yes.
these things has to be there. Otherwise, it's very unlikely the patient is having storm. Okay,
Yes, sir.
please continue.
Yes. Okay, sir.
So just before going forward, like you were
Yes.
telling that even hyperthyroid can cause pancytopenia.
Yes,
So
sir.
in this patient, like how do you differentiate whether it was because of pre-existing hyperthyroidism or it's because of drug-induced, ATD-induced? So what are the features in favor of each of these things and
So
against?
usually hyperthyroid-induced pancytopenia most commonly seen in Graves' disease. So like usually they'll present with pancytopenia. Sir, here the patient when he got diagnosed with hyperthyroidism, he did not have pancytopenia. His CBC was completely normal. Sir. So probably that goes against. Sir. And here once he had a normal baseline CBC characters and then he was started on antithyroid drugs and then he landed in pancytopenia. Will go more towards drug-induced pancytopenia rather than hyperthyroidism itself causing, so because there was a baseline normal CBC counts.
What is the cause for pancytopenia in untreated Graves' disease? What are the causes?
Sir, usually there are like multiple theories have been postulated, sir. One is because of the associated Graves autoimmunity, there can be autoimmunity against the bone marrow precursors causing pancytopenia. There can be increased peripheral destruction and sequestration, so mainly in the spleen that can cause pancytopenia. And it also, because of the immunogenic mechanism, there can be maturation arrest and decreased production of bone marrow precursor cells, probably contributing to pancytopenia.
Oh, go ahead, yeah.
Okay. So the patient was admitted with neutropenic sepsis with septic shock, pancytopenia, and direct hypervolemia, probably attributed to antithyroid drugs. In view of the drug-induced pancytopenia, carbimazole was stopped. Relevant blood, urine, stool, and sputum culture was sent, and patient was started on broad-spectrum antibiotics, inotropes, and IV fluids. The X-ray on admission just showed mild increase in bronchovascular markings, and there was no heterogeneous patch suggesting of pneumonia. USG abdomen pelvis did not show any foci, it just showed grade 1 fatty liver, and echo was normal with EF of 55%. Coming to the day 2 of the ICU stay, the CBC was repeated, which showed further drop in absolute neutrophil count almost to 65, and platelets was 1.19 lakh. The creatinine and electrolytes had normalized because of the adequate hydration and potassium correction, and the main issues being the loose stools and the fever spike, for which metronidazole was added and symptomatic management with loperamide was given. However, on the day 3, the absolute neutrophil count dropped to 0, with platelets dropping to 90,000. So further dropping in pancytopenia, and patient had persistent fever spikes with elevated CRP of 261. Here the hematology and endocrinology opinion was taken. Hematology opinion mainly they advised for filgrastim for 3 days, and if there was no further improvement in the bone marrow picture, they are planned for bone marrow biopsy. And endocrinology opinion was sought, which would and advised for lithium 300 mg twice daily. Also, steroids and TRAB was also advised. However, the primary critical care team, in view of severe sepsis, was not keen on starting steroids and they're told to stop to do the TRAB on for further basis. On the next day of ICU, WFC count was still dropping to total count was 900. Absolute neutrophil count was still 0. There was still pancytopenia. There was still direct hyperbilirubinemia, and FT3, FT4 was almost stable. That previous FT4 was 2.25 and 2.38. It was almost the same levels. However, here sputum culture yielded Pseudomonas and MRSA both were significant growth, more than 10 power 5 colony forming units. And it also yielded typhoid IgM positive with an elevated procal, and appropriate antibiotics according to culture sensitivity was added. The NORAD was tapered and stopped, and filgrastim was continued. And a similar course followed in the next day also. And a similar management was continued, and further dose of the third dose of filgrastim was given. On day 6 of ICU stay, there was transient increase in the absolute neutrophil count, that is 845. However, there was improvement in the platelet count to 1.55 lakh, with persistent fever spikes and G. And since there was persisting neutropenia, bone marrow biopsy and aspiration both was done, and the bone marrow aspiration was sent for culture also. And hematology opined to continue filgrastim till the total count went to more than 5,000, and the absolute neutrophil count remained stable. And hence GCSF was continued in the further course of the hospital stay. And on day 9 of ICU, there was the WFC count came to 11,000, with absolute neutrophil count coming to 4,000. However, fever spikes were still there, and in view of improved and stable neutrophil counts, after 6 doses of filgrastim, it was stopped. And as the patient had recovered hemodynamically and pancytopenia was improving, the option of radioactive iodine ablation was discussed with the patient. However, initially the patient was hesitant for that. So this was the bone marrow aspiration biopsy reports, which both showed the myeloid series was markedly suppressed. However, the erythroid and the megakaryocyte lineage were not suppressed to that extent. And the biopsy report showed mainly a normocellular trilateral hematopoiesis. However, myeloid cells were definitely decreased and a shift to left was seen. And there were no other fibrosis or atypical cells, thus ruling out bone marrow failure syndromes like MDS or myelofibrosis. And there are no atypical cells, thus ruling out leukemias or other causes. And in the further hospitals on day 10, FT3, FT4 was repeated. FT4 was 4.14, almost 2.5 to 3 times the upper normal limit, and similar with FT3. And in view of rising FT4 and FT3, lithium carbonate dose was increased to TID, propranolol was restarted, and similar monitoring was done. However, in the day 10, the total bilirubin and direct bilirubin had come down. That is from 8 to it had come to 3.7. A similar line of management was continued, and patient was shifted from the main to step down ICU. But on the repeat FT4 measurement on day 12, FT4 was still rising 4.8 and FT3 was still rising 23. And in view of rising FT4 despite lithium carbonate propranolol also, injection hydrocort 100 mg IV TID and cholestyramine was started with 4 gram twice a day, and making sure there was no food or medicine intake 1 hour before and 2 to 3 hours after giving cholesterol. After further counseling, patient agreed for radioactive iodine ablation, and patient was shifted on 9 for radioactive uptake scan and ablation. So this was the report of the radioactive uptake scan, which showed toxic MNG like picture, that is right lobe having almost 12.2% uptake and left lobe having 6.3% uptake, confirming the diagnosis of toxic multinodular goiter. And radioactive radioiodine ablation was done with 15 millicurie of radioactive iodine. And after that, patient was shifted back to the wards, and lithium 300 mg TAD was continued along with steroids. Further monitoring of the patient showed that though anemia was persisting, the WBC and platelets did not drop, they were stable. However, probably because of the elevated FT3 and FT4, there was mild transaminitis with 53 and 102. But bilirubin levels were coming down. And compared to the FT3, FT4 of the previous values, FT4 showed a decreasing trend. And since it was almost day 10 of lithium, serum lithium levels was done, and it was 0.8 within normal limits, and procal also had elevated to had improved to 0.14. And on the just the day before discharge, FT4 and FT3 was decreasing trend. Hydrocortisone was tapered, cholesterol was stopped, and lithium and propanol was continued. So final diagnosis at discharge was toxic multinodular goiter, status post radioactive ablation, thionamide induced pancytopenia, which was resolving because anemia was still present, neutropenic sepsis with septic shock, the foci probably being LRTI, however, X-ray was not normal, acute gastroenteritis which was resolved, and acute liver injury was resolving with mild transaminitis still persisting. And the patient was discharged on lithium carbonate TID, prednisolone on tapering dose, propranolol 20 mg TID, and calcium carbonate. Coming to further follow-ups, in the further follow-up after 1 week, it showed that normal CBC count with dropping FT3 and FT4 levels. So oral steroids was tapered, lithium was continued. And in the next follow-up, FT4 was 1.01 and TSH, the suppression, TSH was increasing, that's 0.005. Lithium was tapered from TID to BD, and oral steroids was tapered and stopped. In the next follow-up, TSH had gone to 37 with low FT4 almost of 0.21 with a normal hemoglobin of 12.7. In this visit, lithium was stopped and patient was advised to come after 2 weeks with repeat reports. However, patient did not come after 2 weeks, and patient came almost 1.5 to 2 months later, where TSH had gone to 50 and T4 was 2.24, lower limit. Hence, levothyroxine replacement was started, 100 microgram, and it was continued. And on further follow-ups, the dose of LT4 was adjusted accordingly. And currently, on the recent follow-up, a patient is currently on levothyroxine replacement of 100 on 6 days a week and 50 on 1 day on Sundays. Coming to the discussion part, ATD-induced pancytopenia is documented. ATD-induced agranulocytosis is a documented thing, like the incidence being around 0.1 to 0.5% of the treated patients. However, the incidence of pancytopenia with antithyroid drugs is even more rare, the approximate incidence being only around 0.01 to 0.05%. And it is defined as along with associated agranulocytosis that is less than 500 neutrophil count, if whenever there's hemoglobin of less than 11 or platelet count of less than 1 lakh. This chart shows the brief mechanism of action of the antithyroid drugs, which has both intrathyroidal inhibition of hydrotensin coupling and
You can skip that for want of time because
Okay,
we have time till 8:30.
Okay,
You
sir.
can skip those things, go to the main point.
Yes, sir. The main pathogenesis being of the ATD-induced pancytopenia being it is considered immune mediated process, and partly only in rare cases direct intoxication. So in a susceptible patient, because of the immune mediated stem cell damage, there'll usually be bone marrow suppression, and only in selected patients because of the toxic effect on bone marrow, which inhibits DNA synthesis, thus contributing to hypocellular marrow and aplastic anemia picture. The agranulocytosis and pancytopenia is usually dose related with methimazole or carbimazole, but with propyltyrosol, it can be dose independent, idiosyncratic also. And in one of the studies conducted by Nakamura et al., who analyzed almost 754 cases of granulocytosis, and which showed an incidence of 0.28% in the first 3 months of therapy itself. That is, almost 84% of them were identified within 90 days. And the mean dose of methimazole at the onset of granulocytosis was around 24 mg per day, with the risk factors being higher dose of ATD with older age, presence of certain HLA-DR-B1 alleles, or rare NOX3 genetic variants. And the onset of agranulocytosis is rather abrupt, that is, it may develop within 1 to 2 days, and the most common presentation being pharyngitis. And because of this abrupt onset of agranulocytosis, the guidelines do not recommend monitoring of white blood cells during ATD therapy. So this was one study which analyzed almost 50,000 plus patients with Graves' disease who had ATD inducing, who were the 50,000 plus were treated with antithyroid drugs, and in that only 50 patients had agranulocytosis, and in them only 5 patients had pancytopenia, and the mean onset for pancytopenia was around 41 days. And in most of the time, agranulocytosis preceded the pancytopenia, thus probably indicating that it is of the same pathogenesis, and there's only a difference in the severity. This was another study which was conducted, which analyzed the ATD-induced aplastic anemia over the last 30 years, which showed that most of it was most common because it was most common with almost 78%, 78.6% had methimazole of 30 mg per day. And aplastic anemia occurred within 6 months of initiation of the antithyroid therapy in almost 94% of the patients. And 70.6% of them completely recovered within 8 days to 6 weeks. And there are only very few patients which took more than 4 weeks. And most of the patients usually recovered within 1 to 2 weeks of stopping the antithyroid drugs. And it is interesting to note that almost 47.1% of these patients, that's almost half of this patient, improved just on supportive therapy, that is stopping the antithyroid drugs and with RBC and platelet transfusion. GCSF was given in 82.4% of the patients, and around 60% received glucocorticoids, mainly dexamethasone, and cyclosporin was used in only 15%. And very rarely, and only one patient required ATG, that antithyroid globulin. The treatment of ATD-induced pancytopenia in this this context mainly will be to timely stopping of thiamides, early detection, supportive therapy using blood transfusions, GCSF administration, steroids, usually dexamethasone 4 to 6 mg per day, and immunosuppression centered mainly immunosuppression on and rarely requiring cyclosporin or ATGs. And immunosuppressive therapy may not be essential even for severe case sometimes, hence differing with the aplastic anemia treatment. Recovery happening most of the time within 2 weeks. And few slides on ATD-induced hepatotoxicity. Usually, carbamazole and methimazole predominantly cause cholestatic and mixed pattern of drug-induced liver injury, whereas PTU causes frequently it causes hepatocellular type. The mean duration from onset of ATD to the onset of the DILI was usually 30 days, and usually most of them resolved within 45 days. And whenever there is ATD-induced DILI is considered, immediate discontinuation of ATD should be done. The probable pathogenesis is still exactly not known. However, few products like N-methylthiourea and glyoxal are the major metabolites, major culprits which have been identified, which serve as the basis for liver damage, which leads to edema and inflammation of the portal tract, thus causing cholestasis. However, immune-mediated reactions are also have been said to play a role in ATD-induced hepatotoxicity. The risk factors being for carbamazole and methimazole, mainly it is the advanced age, and for PTU, it is mainly the pediatric age, female gender, and the pre-existing liver disease. And in one of the studies which analyzed antithyroid drug-induced liver injury in more than 70,000 patients, the mean dose of methimazole was around 30 mg, and mean dose of propyltherasol was around 300 mg, which caused hepatotoxicity. And 75% of them, when a trial of alternate ATD was given, it was successful. And since almost 1/3 of the patient with thyrotoxicosis can have baseline transaminitis, usually baseline liver function is usually done, and ATT should always be avoided if the baseline AST/ALT levels are more than 5 times the upper normal limit. And the most effective treatment for ATD related DILI will be discontinuation of the drug. However, this classical that is hepatocellular toxicity being the described predominantly with PTO and methimazole causing mainly the cholestatic has been challenged with few studies showing that methimazole caused more rates of hepatitis, that is 0.25% compared to 0.08% when compared to PTO. And however, the rate of cholestasis was similar for both PTO and MMI, and the rates of hepatic failure are definitely higher in PTO. And the routine ATA guidelines do not recommend routine monitoring of liver function tests, and it should only be done if the patient is symptomatic.
Yeah. Thank you, Dr. Suhas. An excellent case.
Thank you, sir. Yes, thank you, sir.
I think we're already overshot the time limit. Just two small comments from my end. For
Yes.
one thing, that in this background, both are very rare complications, that is ATA-induced hepatitis as well as agranulocytosis. So both occurring together in the same time frame
Yes,
is
sir.
extremely rare. So it's more likely that agranulocytosis is the primary cause, and the sepsis,
Yes, sir.
similar to this ATD, can also cause cholestasis. So
Yes,
that's
sir.
a quite known complication of sepsis. So that's probably is more kind of likely given the context.
Yes,
And
sir.
number two, you said when the ALT is more than 5 times upper normal limit, you should never give ATD. It's not that a strong statement.
Yes.
Okay, you may avoid, of course,
Okay,
but
sir.
since situation like thyroid storm, when
Yes, sir.
ATD is often more than 5 times, or very severe thyrotoxicosis,
Yes.
lithium alone or lithium plus iodine may not control this thing. So
Thyroid storm. Yes,
you
sir.
may have to start
We have
antithyroid
to-
drug and
Yes.
monitor. And most of the
Monitor.
time, it
Yes.
usually calms down. That's a personal experience. I think other
Yes.
seniors and the chairperson, I think they also can comment on that. Thank you. Thank you
Yes.
from my end. So
Okay, thank you, sir. Yes, thank you, sir.
Yeah, just one comment, Dr. Suhas. It's a nice presentation. Ultimately, it came out to be as a toxic MNG, not Graves, what initially we thought of. So, which requires the higher dose of ATD, whether it's the Graves or the toxic?
Usually, toxic MNG requires higher dose of ATD, sir.
No, it's the other way. I think Graves requires
it's not like that. It depends on the severity.
Severity.
Usually, toxic MNG are relatively less severe. Usually, they need higher dose of radioiodine. Okay.
Higher dose of radioiodine. Yes, sir.
Yeah, they usually need higher dose of radioiodine.
Yeah, so as compared to MNG, Graves usually requires higher dose of ATD. So,
Okay, sir.
and this patient probably the dose was 5 tablets was
Yes,
prescribed.
it was higher. Yes, sir. Yes.
Yeah. So ultimately, even we are not very convinced like whether it was basically because of AT-induced pancytopenia or the other differential was sepsis, as you rightly told, sir. So
Yes.
probably maybe both the factors might have been involved in this.
Yes, sir.
Thank you.
Thank you. So over to the organizers, Dr. Ganavi and Dr. Vijayavasham.
Okay, thank you, sir. Thanks.
Thank you. Thank you, Dr. Suhas and Dr. Santosh and Dr. Rana for moderating the session. I think it was a very difficult case to manage, and I think you did a good job to get the patient out of the woods. So over to Dr. Ganavi.
Thank you, sir. Thank you, Dr. Suhas and the esteemed moderators for a very enriching discussion and a lot of practical insights as well. So we now move on to our next segment, that is the topic being the transoral thyroidectomy. So I request Dr. Roma ma'am to introduce the speaker, Dr. Sanjay K. Yadav. Over to Roma ma'am.
Yeah, a very good evening to all. Very nice case presentation, difficult to manage, definitely. So we all know that after a thyroid surgery, what the patient sees in the morning is the thyroid scar, the anterior scar that the patient gets. And this is what actually reminds the patient every day that he or she had suffered for some disease. So that's the reason why the surgeons have always looked for other options so that there is no scar in the neck. So what I do is robotic thyroidectomy through breast axilla approach. And we have here Dr. Sanjay Yadav. He's assistant professor in Jabalpur Medical College. He has done MCH from SGPGI itself. Very dynamic endocrine surgeon. And so let's see how he reaches the thyroid through the transoral approach. Over to you, Sanjay.
Thank you so much, ma'am. Thank you, Dr. Gnavi, for inviting me. So, second, can you allow me for sharing the screen, please? Yes. Is it visible now?
Yes, Sanjay, continue. It's visible. Yes.
Okay. So, good evening, respected colleagues, seniors, and friends. So today I want to discuss something which is very pertinent for majority of our patients. For decades, thyroid surgery has been judged by three endpoints. Usually, was the tumor removed, was the nerve intact, and was calcium normal? But patients judge us differently. They ask, can I speak normally? Can I look in the mirror without being reminded of the disease? And can I return to my life without pain or stiffness of the neck? So today I will speak not just as a surgeon, but as someone who believes that quality of life is not a luxury outcome, it is a core surgical outcome. So, what is expected from thyroid surgeons is that first, do no harm. This principle is deceptively simple. In thyroid surgery, in expert hands, harm is not always dramatic. It is often subtle, it is often chronic, and it is often lifelong. Sometimes hypocalcemia that never fully recovers, or a voice that tires by the evening, a neck tightness or neck pain that no CT scan can explain, or a scar that silently alters the body image. So, uh, for majority of our patients, a scar is not cosmetic; it may be psychological. So, a neck scar is not always neutral. And particularly for our young women, it affects self esteem, social confidence, and identity. So, when we dismiss scar as something cosmetic, we invalidate lived patient experiences. So, quality of life, that's why quality of life is a core surgical outcome. And I like to conceptualize this thyroid surgery outcomes as a quality of life wheel. It is not a checklist, it is a system. And each spoke matters. If even one spoke is weak, the wheel does not roll smoothly. So, our goal is not always survival alone. Our goal is to balance this wheel. So that is why the totally endoscopic thyroid surgery emerged, and it was pushed by surgeons due to excellent magnified view and safe procedure in trained hands, along with excellent cosmetic outcome. But let me tell you this very clearly that technology does not forgive poor fundamentals. That is why what I usually teach my residents and those who are interested in endoscopic thyroid surgery, 10 commandments of transoral endoscopic thyroid surgery. So the first and foremost most important is thou shall master open thyroid surgery first. So, and I often quote Bill Roth here. Only a man who is familiar with the art and science of the past is competent to aid in its progress in the future. That is why open thyroid surgery is the base of any advanced thyroid surgery. And in our own tradition, also, it is said that as the root, so the branches, as the seed, so the fruit. So if anyone's open surgery is sloppy, then endoscopic surgery will become obviously dangerous. So second commandment is, thou shalt choose patient and technique wisely. So I want to emphasize here that not every thyroid needs to be scarless. Not every patient needs endoscopy. So a good candidate for endoscopic thyroid surgery should not be defined by the surgeon's enthusiasm. They are defined by the biology, anatomy, and expectations of the patient after a clear counseling and discussion with the patient. And these matters more than the surgeon's ego. Then there are myriads of approaches. I will be briefly speaking on transoral approach. Then third commandment is that one should always respect the learning curve. There are no shortcuts to mastery. Then other remaining three commandments are actually related to the actual thyroid surgery, transoral endoscopic thyroid surgery, that is creation of sufficient working space, searching for midline and dividing the isthmus, separating straps from the lobe, and identifying middle thyroid vein, identifying external branch of superior laryngeal nerve and superior pole vessels, identifying recurrent laryngeal nerve at its entry point, and then completion of the surgery. So this is the vestibular marking for transoral endoscopic thyroid surgery, and this is after port placement. This is short video. So this patient has a benign right-sided thyroid nodule. I will skip few parts. So this is creation of subplatysmal working space. So as you can see, the magnification helps a lot. Then this is division of the midline linea alba. After opening the midline, the strap muscle is separated from the thyroid nodule. Here we have developed our own technique of ultrasound guided preoperative hydrodissection. So that makes this dissection very smooth and decreases the overall operative time. Then isthmus is being divided while the trachea is always in the view. So division of isthmus is complete. Now we have focused our attention towards the superior pole of thyroid. So that's the superior thyroid artery. You can see that pulsation clearly there. After ligating it with bipolar sealer, the superior pole comes out of the thyroid fossa. And this is another our low-cost innovation of using a muscle retractor made of spinal needle. So that's the muscle retractor there. So if required, we apply it. After that, this is something we call it critical view of safety. So this area we can identify recurrent laryngeal nerve while it enters into the trachea. You can see that that's the recurrent laryngeal nerve. It has come into picture. Once we have identified it, we will proceed further, divide the lateral attachments, and then specimen will be taken out. So that is how with these low-cost innovations and indigenous muscle retractor, we have decreased the operative time of transoral endoscopic thyroid surgery. And critical view of safety helps us in identifying the recurrent laryngeal nerve. This is the cosmetic outcome. So again, coming to our central point, quality of life. So our experience, we have compared swallowing related quality of life in open versus endoscopic thyroid surgery, and we found that this particular parameter was better in those patients who underwent endoscopic thyroid surgery. Then the endoscopic surgery for treatment of papillary thyroid carcinoma. So the real question is not can we remove cancer endoscopically, but more important point is that we can do so without compromising the oncological safety. So oncological safety should be the first parameter while deciding for an endoscopic thyroid surgery for thyroid carcinoma. So we have performed this endoscopic thyroid surgery in around 30 patients, and the quality of life, most importantly, cosmetic satisfaction was better in endoscopic thyroidectomy group. But what we found that long-term quality of life was better in both the group, was similar in both the groups. So another a low-cost intervention which impacts the quality of life significantly is this another meaningful finding from something very simple, pre-operative neck stretching exercise. This is associated with less pain, better perceived recovery, and improved early quality of life. So that is why in thyroid surgery, sometimes the biggest gains may come from thinking beyond the operation itself. So I will end this with this thought that surgery is not just an event. It may be just an event for us surgeons, but for patient, it is an experience with a long echo. So we must evolve from did we remove the gland to did we preserve the patient. So when oncology, function, cosmesis, psychology, and equity, everything align, that is when thyroid surgery becomes truly modern thyroid surgery. So again, closing this with our own scripture, that a task when discussed thoroughly and decided by reason leads to successful action when executed together. So together is the team, and this team must involve patient always. Thank you for your attention and your time. And I look forward to any questions or discussion. Thank you so much.
Yes, thank you so much, Dr. Sanjay. It was a wonderful talk, and it was really nice to see the work that you have done. Any questions? Anyone from endocrinologists? At least we want some questions. Dr. Vijay Bhaskar, any comments or anything? Do we have any questions in the chat?
Ma'am, none in the chat box as of now.
It's good that we are hearing the different approach. My only question is there any size limit? for nodules?
Yes, for transoral endoscopic thyroid surgery, definitely nodules less than 5 centimeter are preferred, because biggest challenge is to taking them out through the oral cavity.
For malignancy,
Sanjay,
the
I
lymph
think
node dissection is possible.
Yes, yes. For malignancy, we can do central compartment lymph node dissection through transoral approach, and that is being done extensively. Yes.
But what about the tumor seeding, sir? Like, if at all, if it is malignancy?
Yes, so the tumor seeding risk will arise only if we rupture the nodule without putting it inside the retrieval bag. Otherwise, it is safe.
And what about
Ganavi,
for
yeah.
all types of cancers, can we use it or only for papillary, follicular? Like, is it specific, the nodule, the cancer should be specific, or can we use it for all nodules? So if the calcitonin is high and the nodule is there, and can we use it for all range of cancers or only follicular, papillary? If we are suspecting, then we can go for it.
Yes, so this actually depends on the size of the tumor. Suppose it is a medullary thyroid carcinoma, but screen detected 1 centimeter, 1.5 centimeter, that can jolly well be taken out through the transoral approach. But for bigger tumors, obviously, for medullary thyroid carcinoma and especially follicular thyroid carcinoma, those are very vascular, so it becomes very challenging.
Okay. Thank you, sir.
Yes, I think Dr. Sanjay, it was wonderful. Just one thing I want to add. In your 10 commandments, there was no mention of the parathyroids, which should be there, right?
It is
Yes.
a text in the article, it is there.
Okay, maybe. Yeah. So I was more concerned about the parathyroids, definitely. Anyways. Any more questions? Can we close the session then?
Yes, ma'am.
Yeah. Okay. Thank you. Thank you,
Thank
Dr. Sanjay. Thank you, Ganavi. Thank you. Yeah.
Yes, ma'am. Thank you, Dr. Sanjay and Roma ma'am, for a very interesting talk and moderation on transoral thyroidectomy. So definitely the surgical nuances, the patient selection, all of this was very, very, and also the steps were very valuable. So again, to proceed further, I request the tech team to display the QR code by which so those who are interested to submit the journal to the Thyroid Research and Practice, which is the flagship journal of Indian Thyroid Society, can do so by scanning the QR code. And those who are interested to become reviewers for Thyroid Research and Practice can again do so by scanning the QR code displayed on the screen. And now moving on to everyone's very favorite segment, that is the quiz session. So we will have questions followed by answers for the quiz. And regarding the quiz roles, so to participate in the quiz, click on the attend quiz button, which is displayed on the screen and is being live streamed. The quiz will be conducted through a platform called as Slido. So you're requested to use a laptop for the ease of experience. The quiz will run for about 5 minutes. The quizmaster will display the case or description of the question by screen sharing a PowerPoint file, and there'll be 10 questions. Each question will be available for 30 seconds with the timer on, and do not refresh the page or go back to the previous page. So with that, moving on, we have our very dynamic endocrinologist, Dr. Pooja Kamath. She is a consultant endocrinologist at Manipal Hospitals, Malleshwaram, Bangalore, who is our quizmaster for today. And it is my privilege to be introducing her. She is one of our students as well. So, she's received many awards. She's also received the ESI grant for research in 2021 and won numerous prizes for oral and poster presentations at various platforms, including Essicon, Hormone Rhythm as well. And she has multiple publications at National Journal as well. So, Dr. Pooja, we are eager and ready for the quiz questions. So,
Thank you so much for the kind introduction, Gani ma'am, and even I'm happy to be here. So I'll just start off with the quiz. So firstly, we have the quiz for the DM students, and for the practitioners, the quiz was already out, so we have to see the results. So shall we start, ma'am? I'll share the screen.
The tech team will tell you when to start. Just the people will be joining through the Slido.
Start after 1 minute, ma'am?
Yeah. You can wait for a minute, Pooja, because the tech team, the people will join through the Slido, so they'll just take a minute to join. That's why.
Yes.
Ma'am, you can start.
Okay. So I should share the screen or like.
Yes, ma'am. Yes.
Yes. Okay. Okay. Can you see the screen?
no, Pooja, we are
No.
still not able to see.
No, we are not able to. Now it is coming.
Okay.
We can see, we can make it full screen. Yeah. Yeah. Done.
Okay. So let's start the quiz. So I know all of you are waiting for the questions. So they are easy and little bit of clinical takeaway points are there. So the first question is, what is the primary clinical concern regarding the increasing use of rock salt or pink salt in India? Option A, hyperthyroidism due to naturally high iodine concentrations. Option B, only recommended salt for patients with non-communicable diseases. Option C, therapeutic levels of calcium that interfere with levothyroxine absorption. And option D, lacks iodine and could create pockets of population with inadequate iodine intake.
Next, ma'am.
So coming to question number 2, which of the following represents a proposed mechanism linking the gut to thyroid autoimmunity? The first option, gut bacteria produces excess TSH-like substances. Second option, increased intestinal permeability allows gut microbes to directly infect the thyroid gland. Option C, gut bacteria compete for and deplete systemic iodine. Option number D, amino acid sequences on certain gut bacteria mimic human thyroid antigens, triggering a cross-reactive immune response.
Next, ma'am.
Coming to question number 3, a 45-year-old patient on methimazole for 2 months presents with agranulocytosis. What is the stance on cross-reactivity between methimaz and PTU for agranulocytosis? Option A, switching is permitted if the initial reaction occurred after 90 days of therapy. Switching to PTU is the first-line recommendation to maintain euthyroidism. Option number C, cross-reactivity is only a concern for skin rashes, not for hematological complication. Option number D, the use of alternative ATD is generally contraindicated due to high risk of cross-reactivity.
Next, ma'am.
So the questions are going to get tougher now. So clinical significance of red proto-oncogene germline mutation at axon 11 in medullary thyroid cancer. This mutation suggests a better prognosis. It confirms that medullary thyroid cancer is sporadic and unrelated to any other endocrine dysfunction. Option number C, it indicates a low risk of syndromic association and limits the need for family screening. Option number D, it strongly suggests MEN2A and necessitates screening for pheochromocytoma. So coming to a case scenario, a 65-year-old male with papillary thyroid carcinoma presents 4 years post-op with weight loss and suppressed TSH while not taking thyroid medications. Lung fields show uptake on the radioiodine scan. What does this case highlight regarding metastatic disease? Option number A, the patient has a coexistent secondary primary malignancy in the lung. Option number B, distant metastasis can be functional and present as thyrotoxicosis. Option number C, lung metastasis in papillary thyroid cancer is always non-functional and requires chemotherapy. Option number D, suppressed TSH in this case is due to excess levothyroxine use.
Next one.
Coming to the next question, in a patient with hypothyroidism with persistent symptoms despite normal levothyroxine treatment, patients was started on LT4 plus L3 combination. So what is the recommended LT4 to LT3 ratio? Option number A, 7:1 to 12:1. Option number B, 13:1 to 20:1. Option number C, 21:1 to 28:1. Or option number D, 29:1 or 35:1.
Next.
Molecular markers are most useful in which Bethesda's category of thyroid nodule? Bethesda 1, 3, 5, or 6? Which is the maximum permissible dose of radioiodine as outpatient as per the Indian guidelines? Option number A, 15 millicurie. Option number B, 30 millicurie. Option number C, 45 millicurie. And option number D, 60 millicurie.
Next.
Coming to the case scenario, in a 73-year-old female presenting with thyrotoxicosis and a large pelvic mass, technetium 99 nuclear scan showed absent uptake in the neck. So you can see the figure where there is absent uptake in the neck. So what is the most appropriate diagnosis? Option number A, struma ovary. Option number B, factitious thyrotoxicosis. Option number C, malignant struma ovary with neck metastasis. Option number D, subacute thyroiditis with an incidental ovarian Brenner tumor.
Yes.
Coming to the last question on which we had a session today. So, which of the following is considered the most common approach for transoral thyroidectomy? Vestibular approach, sublingual approach, floor of the mouth approach, or suprahyoid approach?
Yes, ma'am.
So that's the end of the DM quiz. So until the tech team tells for the results, we'll just go through the answers once. So I'll just share. So coming to the first question, this was the Indian Thyroid Society guidelines was released on the use of salt, universal iodinization program. So the answer is D, lacks iodine and could create pockets of population with inadequate iodine intake. So often what patients think, or we have to educate patients, that is that rock salt is often marketed as healthy alternative, but it typically doesn't contain the sufficient amount of iodine. So basically 15 to 30 parts per millimeter is what is the universal guideline says. So that is the thing which a thyroid patient should usually be asked for. Coming to the second question, so which of the following represents a proposed mechanism linking the gut to thyroid autoimmunity? Nowadays, gut health or the gut dysbiosis has become the topic where molecular mimicry plays an important role. So, amino acid sequences on the gut bacteria mimic human thyroid antigens, triggering a cross-reactive immune response was the answer. So this is the figure which shows where the dysbiosis between the gut microorganism, the antigen present on the own bacterial protein is present as a molecular mimicry, and that structurally attacks the proteins like thyroid peroxidase. Coming to the third question, the question was whether you can use, if the patient is on methimazole and develops agranulocytosis, can he be started on PTU? No. The use of, especially when a patient has a major side effect, a severe side effect, that is the hematological complication, because of high risk of cross reactivity. But the ATA guideline says that you can use it if you have a little bit of skin side effects such as rashes, but not for major side effects such as agranulocytosis, making the D as the answer. Coming to question number 4, this mainly this mutation is seen in men 2A, and it necessitates screening for FEO. So whenever you see a patient with medullary thyroid cancer, the genetic testing is very important to rule out familial or sporadic part. And there, this was a case report where the screening for FEO as well as hyperthyroidism has to be done once the high risk variant is seen. Coming to question number 5, where the patient who was post-op after having diagnosed with the papillary thyroid carcinoma and had a suppressed TSH. So in such a case, even though he was not taking thyroid supplements, he had a suppressed TSH. So the answer is distant metastasis can be functional and present as thyrotoxicosis. This metastatic PTC usually retain iodine trapping and produce hormone to suppress the TSH, and that can result in clinical thyrotoxicosis. So the key takeaway point is functional metastasis should also be suspected if there is minimal TSH suppression. In a patient with hypothyroidism, the ratio of LT4 to LT3, usually it is 30, the answer is B. So 13:1 and 20:1 by weight, and LT4 once daily and LT3 in 2 divided doses it is given. And this was the consensus statement from the Indian Thyroid Society, where they have given when to add LT3 and how to go about with the dose. Coming to question number 7, so which are the molecular markers? When do we use it in which Bethesda? Mainly when the answer is 3, Bethesda 3 here in the options. Usually it is done to to differentiate between benign and malignant thyroid nodules, especially with indeterminate thyroid nodules. If the patient doesn't say is not ready for FNAC, or if the nodule is very small where you can't do an FNAC, and this can help in differentiating between the malignant and the benign part. So coming to the next question number 8, what is the maximum permissible dose? It is 30 millicurie according to the radiation safety guidelines from India. So the iodine high activities up to 30 millicurie can be given. So coming to this question of clinical, where there was no uptake in the thyroid, though patient presented with thyrotoxicosis, there was no uptake in the neck. So the uptake was seen in the ovary. So struma ovary is where 50% of it has thyroid tissue, and only some produce thyroid hormones. So in case if there is a case where the TSH is low and you don't find any uptake, you should screen the abdomen for ectopic thyrotoxicosis when there is absent neck uptake. Coming to the last question, the answer was vestibular approach. So the most common approach, as we saw the discussion today, for transoral thyroidectomy is vestibular approach. So this is mainly considered for low-risk cancers and basically less than 1 centimeter or unifocal, or no evidence of lymph node metastasis, or no invasion of surrounding structures. Thank you. So the results of the DM quiz.
Dr. Pooja, can you also discuss the practitioners?
Yes, ma'am. Yes, ma'am.
You can put it on full screen mode, Dr.
Yes, ma'am. So, so coming to the practitioners quiz answers. So the first question was, what is the primary physiological mechanism responsible for hung up reflex or delayed relaxation of ankle jerk in hypothyroidism? So it, as you all know, it is decreased activity of calcium ATPase in the sarcoplasmic reticulum was the answer C. So basically the mechanism is where the reuptake into the sarcoplasmic reticulum is an energy dependent, and reduced calcium ATPase activity in hypothyroidism slows this reuptake and prolonging the relaxation phase. That's the main mechanism. Coming to question number 2, a 50-year-old female with primary hypothyroidism has been on levothyroxine for a year. Her TSH is within the target range, but she continues to report significant fatigue and poor concentration. Other comorbidities have been ruled out. So what is the next appropriate step? So consider a 3-month trial of LT4 and levothyroxine LT3 therapy. Option number 4 was the answer. So this is where you consider LT3 therapy, as you can see in the figure. So for compliant patient with persistent symptoms despite normal TSH on LT4 monotherapy, a trial of combination therapy is usually suggested as an experimental approach, given that patient preference for its high resolving of symptoms. Coming to the next question, which factor is the most critical for improving health-related quality of life and reducing fatigue in children with congenital hypothyroidism? So option number C was the answer: early diagnosis and prompt, consistent initiation of levothyroxine therapy. So this was an article which research strongly indicates a negative correlation between the age at therapy initiation and the scores. So emphasizing that early initiation and uninterrupted treatment will give better outcomes. Coming to question number 4, a 68-year-old male is admitted to ICU with an acute ischemic stroke. His family reports no prior history of thyroid disease. Which thyroid hormone abnormality on admission is most strongly correlated with worst functional outcomes? So the answer was low. The answer is low free T3. So research has shown that negative correlation is there between the admission free T3 levels and favorable outcomes. So like linking low FT3 with more severe or more stroke outcomes and greater disability. So coming to the next question, iron deficiency is diagnosed in approximately 60% of subjects with autoimmune hypothyroidism. So what is the key role of iron in thyroid hormone synthesis that is impaired by this deficiency? So answer B, iron is a component of, as you all know, the thyroid peroxidase enzyme. So this was an easy question, and TPO is essential for both iodination of thyroglobulin and coupling of iodothyrosins. Coming to the next question, what is the suggested next diagnostic evaluation for a patient with thyroid nodule with suppressed TSH? So it is the nuclear scan, option number C, thyroid scintigraphy. So as per guidelines, if the TSH is suppressed, the total T3, total T4, and the next step should be thyroid scintigraphy. Which system is recommended by Indian guideline for reporting thyroid cytology? It is the Bethesda system. So this is, we follow category 1, 2, 3, 4, 5, and 6. A 30-year-old pregnant lady at 12 weeks of gestation with TSH of 0.7 and free T4 of 0.5 nanogram per DL. What is the next step? So it is B, reassure as normal TSH, because usually it is that isolated hypothyroxemia should not be routinely treated in pregnancy. What is the equivalent dose of propylthiouracil for 10 milligram carbimazole? It is 100 milligram. Answer B. Question number 10, the last question. The most common genetic mutation seen in papillary thyroid carcinoma affects which gene? So it is option number A, BRAF gene. So coming to the end of the practitioner's questions, let's see who has got first, who are the winners of both the quizzes.
Tech team, can you display the quiz winners for both the practitioners and today's quiz?
Sure, ma'am.
Can you display the names, please?
Ma'am, these are the winners for today's quiz. And for practitioners, we'll display later.
So Dr. SP, Dr. ABP, Dr. K, we request you to submit your full names so that the certificates can be sent over. Tech team, can we have the winners for the practitioners quiz as well? Dr. Pooja can announce the winners.
So the winners of the practitioners quiz, the first winner is Dr. Hamsa VS. Congratulations. Winner number 2 is Dr. Sudha M. And winner number 3 is Dr. Muhammad Ghosh. Congratulations to all the winners. So I hope you have benefited from the quiz with clinical takeaway points.
Thank you, Dr. Pooja. That was indeed a very fantastic quiz, and congratulations to all the quiz winners as well. And moving on, before we conclude, I would like to request Dr. Pramila ma'am to give the concluding remarks.
Yeah, thanks, Dr. Danvi. I think we had a very interesting discussion starting with the anti-thyroid drugs side effects, because we know that we all use so much of anti-thyroid drugs, but the side effects, though rare, but we see it quite commonly. The side effects, if we discuss agranulocytosis and liver dysfunction, and which we should always be aware of. And the most important thing is we should make the patient aware of it, because that's what is the most important, so that they can present at the right time. And also we had the interesting lecture on the transoral thyroidectomy, and we all had a lot of learnings from that as well. And then the quiz, it was a pleasure that Dr. Pooja conducted the quiz today. So it's nice that
thank you.
it's nice
I
that our
missed all of you.
students. We too. So it's very nice that our student is now conducting the quiz, and she did it so well. So I congratulate all the winners as well, and our ITS clinics team as well, because I think the DM students definitely wait for the thyroid clinics to come up every month. And also I again request the DM students also to tell other students as well to join the thyroid clinics and attend the thyroid clinics, because this is meant for students. So that's why we are doing it. Even the MD medicine students can attend it and can have a lot of good learnings from it. And I also request everybody to please become the reviewer with thyroid research and practice. And if you are a faculty, if you have done your DM endocrinology, if you are an endocrine surgeon, if you are a nuclear medicine specialist, you are most welcome to become a reviewer with the thyroid research and practice. This is our journal of the Indian Thyroid Society. And I also request all the faculty and the students to submit their articles to Thyroid Research and Practice Journal, which is again the journal of the Indian Thyroid Society. So with this, I hand it over back to Dr. Danvi to carry the proceedings forward.
Thank you, ma'am. Thank you. So, the next thyroid clinics will be on March 11th. Thank you all for joining, and we would love to host you again for the next session. So till then, good night, everyone. So thank you. Have a wonderful evening. Good night.
Good night, everyone.
सर्वमिदं विभाति।